Hello, and welcome to the Sex and Wellness Podcast. My name is Dr. Mary Grimberg, and today I'm here with Dr. Adrienne Gobe. She's an orthopedic and pelvic floor physical therapist. She is certified in women's health through the American Physical Therapy Association. She also educates other healthcare providers on pelvic health and pelvic floor dysfunctions. And she has a practice here in Austin, Texas that specializes in complex orthopedic and pelvic pain, as well as helping people with sexual dysfunction. So thank you, Adrienne, for coming today.
Thanks for having me. This is going to be so fun.
Adrienne and I go way back. We've talked a lot about pelvic floor dysfunctions and, you know, how so many people are underserved in this population.
Yeah. I mean, if you see me on the street and you want to talk about pelvic health, I'd love it.
So you'd want somebody to stop you and be like, hey, let's talk about my vagina.
I mean, yes. Absolutely.
I mean, that would be kind of awesome.
I was on a play date this weekend and a parent who was actually not even the vulva owner was like, hey, I know somebody that I think, and then we talked about it. And I was like, yeah, sure. I can talk about it while I'm on a play date.
Yeah, totally. I mean, it's a part of my life now. It's like when I go to parties or get-togethers, people are like, you do what? I'm like, yep. I talk about vagina, orgasms, and buttholes all day.
That's
and
right.
I'm proud of it. And I really
Pee-poop
feel
and
like
sex.
I've found my calling. But speaking of which, all righty. We have a a message from Gina from Rochester, New York, who has some questions about orgasms.
Hi, Gina.
Gina. All right. Hi, Dr. Mary. I've been too embarrassed to ask this to my healthcare providers, but since having my 3 children, my orgasm intensities have decreased. My last child was about 5 years ago. Is this normal? If not, is there anything I can do about it?
Yeah.
So, you know, when reading this question, it makes me think, how many other people are thinking this, you know? And I hear it a lot in the practice. It's like, oh, sex is supposed to be not as enjoyable after having kids, which I think is a load of shit.
It happens a lot. So I like to normalize it, like common humanity. So a lot of people are having that experience, but it doesn't have to be normal.
Yeah.
Like
it's common, but not normal.
Thank you. Yes. And I do think we have data to suggest that due to our healthcare providers' own discomfort about talking about sex and sexuality on top of patients' own discomfort, like Gina was so brave to talk about this.
Yeah.
But we have evidence that like if we don't specifically ask about sexual function, it won't be reported. So
yeah, I mean, I've personally never been asked.
Yeah.
Hey, how's
your orgasms?
Yeah, never. I mean, unless we've had conversations with my other healthcare practitioners that are in pelvic health. Even that's the thing too, is like even in training, like in PT school, we didn't learn this stuff. This is stuff that we did extra training on years later and, you know, really relied on continuing education courses, which are courses that you take after, talking with other healthcare practitioners, and really everybody coming together and having these conversations. Because if we're not talking about sex, I mean, it's a major part of life.
Yeah, I remember when I first started out as a pelvic floor therapist, I was like feeling discomfort with talking about sex and sexuality and specifically orgasm and masturbation. And so I really am like, I like Con Ed, like I like taking classes because it feels like, okay, I can talk about this now. So I took this course from Holly Herman, who is amazing. She does a lot on sex and sexuality and sexual function and has done a lot in our fields. But basically, I took this whole course just to be like, how do I talk to my patients about masturbation and orgasm? And they were like, you just say like, hey, do you masterbate? And I was like, oh.
Just stop overthinking it. Just ask, right? Because we're all doing it, right? Yeah. It's like, and it's just so important. But I don't know about you, but I mean, I grew up in a very strict household, in a very strict community, in a very purity culture, which I've seen in some of my clients. It's hard because it's like, well, okay, you know, you're told sex is bad, 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 and then all of a sudden it's not when you're married in that culture or in that, you know, religion. And even just taking away that for me, it's taken me a lot to really sit down and have these conversations and have a podcast about orgasms.
Yeah, totally.
I mean, that's
a big step. I mean, I definitely think we see here in Texas, I have seen a lot of people that are sort of deconstructing purity culture, and
Yes.
that is impacting their sexual function. But even like coming and talking to somebody about sex and sexuality and orgasm could feel like they're doing something wrong.
Totally. Yeah. I've had clients be like, because if, we break down, what we'll do is kind of just break down what happens with arousal and orgasms and stuff like that. But really, sometimes in part of pelvic floor physical therapy, we need some clitoral stimulation, especially if you're having pain with sex, because that dilates the vagina and then the uterus and cervix pull up to allow for penetration. And so if there's no form of clitoral stimulation or foreplay, that's not happening. And there can be some guilt and shame around masturbation because of the purity culture. So whether or not sometimes that applies to people, sometimes it doesn't. But when we're talking about this stuff, we're human beings with, with genitals and sexual needs or desires, excuse me. And and having those needs I keep saying needs, but desires. And being able to have these conversations, because a lot of issues around sex are due to lack of communication or just not knowing what you like or what you don't like and stuff like that.
One of the first things I give people who have changes in their sexual function around any part of their life is something called sensate focus. It's from the therapy, like mental health therapy literature around communication. And so it's like a graded exposure program so that you and your partner can start experimenting with touching other places that aren't your genitals, because there are places that can improve arousal that are not just genitals. And like, I think
with the erogenous zones.
Yes. But also like with how easily accessible pornography can be, sex sort of has become this like formula based on like whoever invented the porno flick, I guess.
Just the one porno flick?
But you know what I mean?
The original porno flick.
But I mean, it's like, no, like, okay, first I do this, then I do this. But like,
it's not like that.
For my couples that are older, that were able to experiment without like a recipe, they have like statistically higher scores on the female sexual function index, because they're like, they just know what their body likes, and they know how to communicate those needs. And those are like big, important, and difficult skills to develop.
Well, yeah. I mean, it can be uncomfortable to talk about these things, especially if you haven't talked about them before. But one of the bigger things that I have people do is like, if self-stimulation or masturbation, because if you don't know your body, you can't articulate that to your partner.
Absolutely.
And so, you can try stuff together, but the reality is, when you don't know, it's like if I had, was hungry or something, right? And maybe this isn't the best example.
No, it's a great example.
But I'm like sitting here
about what you wanted, or you weren't sure.
Yeah, and then I want you
to figure it out.
And then I'm going to get mad at you.
So I'll just
when
like
I don't.
feed you random stuff and see.
Yeah.
And I only know how to make really like a peanut butter sandwich.
Based on what you saw on TV.
Yeah.
That first porno flick that was ever made. And here's the thing is like, whatever people's opinion is on porn, it's that what we're saying is more of that shouldn't be used as education.
No.
It should not be used as education, because a lot of the porn that's out there is based on the heterosexual male,
The male gaze.
Yeah. And so that doesn't really, and so what I've seen in my clinic is vulva owners coming in and saying, listen, I can't orgasm the second, my partner penetrates me. I'm like, that's not normal. That takes a long time. And that, and then I talk about the physiology behind it, right? So it's like, okay, so you start getting aroused, the vagina dilates again. Lubrication occurs. Sometimes people can't have enough lubrication, but but that doesn't mean they're not aroused. And then your cervix and then uterus pull up, so it allows the lengthening of
the vaginal canal,
the vaginal canal to allow for penetration. And so that's really important because if you don't do that, it's going to be painful. You can hit, hitting the cervix or like the initial penetration, like some of those things, it's not ready for penetration yet. And then you get this other side of this guilt, like, oh, I can't perform like I used to, or da 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 da. And it's like, no, that's kind of the society's expectations that have set us up. Yeah. And one of my favorite books to read was Come As You Are by Dr. Emily Nagoski. And I really think that opened up this whole world of just stopping the shame.
Yes.
And allowing women or people with vulvas to enjoy their sexuality because for years and years, it was not a priority.
Yeah. It's more performative.
Yeah.
And I think that being postpartum, it can impact arousal in so many ways. There can be a hormonal component. There could be like if you have weakness of your vulva or any scar tissue that could like inhibit the vaginal canal from lengthening.
Yeah, let's go back. Let's talk about, so she's not postpartum any time after birth, you're postpartum. You can be postpartum like 50 years after birth, you're still postpartum, but she's a few years. But let's just kind of talk about why people's orgasms might be changed. So go ahead, let's talk about the estrogen.
Yeah, so if you are in either menopausal, perimenopausal, immediately postpartum, you're going to have a drop in the amount of estrogen you have available in your body.
Yeah.
And so estrogen is a very important hormone for the structure of your vaginal mucous membranes. And so it basically is the scaffolding that keeps your mucous membranes like thick.
Yeah.
And so when we have a decrease in estrogen, the tissue becomes more friable, which means like thin and tears easily. You have less lubrication. And so that is not as enjoyable to be penetrated if you have like a vagina that's more likely to be friable or tear and less lubrication, especially if we're talking about penetrative sex specifically.
Yeah. And just like the wall becomes thinner, that lubrication isn't there. The muscle, and the other thing that happens when there's a decrease in estrogen is the muscle weakness can occur just because your muscles aren't as strong or have the tension like they used to. And just kind of adding on, Adrienne was talking about after having a baby. But the other thing, is it can happen after having a baby. But if you're breastfeeding, there is that drop in estrogen as well while breastfeeding.
Yes. Anytime that you're lactating, you're going to be in a decreased estrogen state.
Yeah.
We're kind of in a phase right now, like with Dr. Rachel Rubin, she's really pushing the vaginal estrogen, which is exciting because there was a lot of fear around using topical estrogen. Ultimately, that's between you and your provider, and it's your body. But there is a lot of more acceptance around using topical estrogens, which can be really beneficial for people that are having sexual pain or weakness or, decreased sexual satisfaction.
Totally. Yeah. And so I know there's a big fear around topical estrogens or estrogen. So basically what she's saying is it's not, you're taking it orally, you're inserting it intravaginally or on the outside of the vagina or outside of, around the vulva as well. There's tissues there that can get thinner. This isn't about orgasms, but this is also why you can get repeated UTIs because you can, the urethra is right in there at the vaginal opening. And so if you get little micro tears in there, that could be repeatedly causing some of the UTIs. But I do think that there is some hesitation. I think there's been some misinformation about estrogen in the past, just like, other medications and things like that. But the one thing to consider is that I find in my clients, most of my postpartum people want to wait 12 months or whenever they're done breastfeeding, if they are breastfeeding. Yeah. And then the people that are pre and post menopause, they're more likely, in my experience, to be like, okay, because it's not necessarily coming back like postpartum would.
I would say up until this big push recently, I agree. There have been some of my clients that are lactating that are fearful about impact on supply, the breast, like milk supply.
Okay. Yeah.
And, if you talk to lactation consultants, they kind of are like hesitant. And I would say, if you have a well-established breastfeeding relationship and this is like significantly impacting your quality of life, give it a try. It can be expensive, but it's ultimately like a cost benefit ratio where instead of like waiting, at least here in Austin, and I don't know about other places, people are choosing to have extended breastfeeding relationships. So past 12 months, up to 3 years. So I'm like, I don't want people to have to change their breastfeeding goals because they can't have sex.
Yeah, that's true. Yeah. Just knowing, here's the deal. It's like knowing the resources are out there,
what
right?
options are available.
And whether you're choosing to breastfeed or you're choosing to breastfeed or not, or you're doing it for longer than 12 months, like the goal really, and what you'll all hear about this in this podcast is to provide you with objective information. I'm not going to tell you what to do or not to do because I don't know your body as well as you. Nobody does.
No.
And so, so it's just some stuff to think about. I will say actually too, so I'm a cancer survivor. I had Hodgkin's lymphoma in 2019 and went through 8 rounds of chemotherapy. And I will say that can change the estrogen in your vagina too. And so that was something that nobody talked to me about. I wasn't aware of that was an issue. And so, so that's also something that can happen too. So somebody that's had radiation to the area
definitely,
or chemotherapy, even though mine wasn't a gynecological cancer. I mean, when you get chemotherapy, it's going to affect your hormones. I mean, systemic. I lost my period for a few months and then it just kind of went all out of whack and nobody really knew what to do. They were just like, deal with it. I'm like, okay, cool. Like dry vaginas forever.
I know. And it's hard because it's like the main goal is to,
to live,
to get rid of the cancer, but also like you want to, like no matter your age, it's like you want to be a full person. And hopefully that includes sex and sexuality.
Yeah. Yeah.
Hopefully.
Yeah. Well, that's what they want. But yeah, exactly. But no, so kind of going back to that. So those are some factors that can affect orgasms as well, if we're thinking about it from a hormonal perspective, but also, is there pain, right? So if there's pain, you're less likely to want to do something if it's painful, right? Even if you knew it was enjoyable before. For example, if you love eating cheeseburgers and you just had jaw surgery, are you going to want to eat a cheeseburger? No, you're not. You're going to be like, shit, this hurts. I want to sleep. I want to rest. And so that's also something to consider too. Is she having pain? We didn't get enough information on that, but if these vaginal births, did she tear? And so if you think of the pelvic floor muscles, you've got these 3 layers, and I'm just going to show a picture here, on the model here, but you can see there's 3 layers of the pelvic floor. And that vaginal opening, usually most people tear. If you're thinking about the vaginal opening, the 12 o'clock, think of it as a clock. A 12 o'clock position is your clitoris. The 6 o'clock position is your rectum. And then everything else is kind of around there, right? So most people roughly tear around the 6 o'clock. Yeah.
Yeah. And, if she's 3 years postpartum, there's a possibility that she could have had an episiotomy, which, is usually done either at the 6 o'clock position or they'll do it out to the side. But yeah, if there's some discomfort there, that's going to impact your ability to orgasm. Absolutely. I mean, even if it's, even if you can orgasm, it may take longer or it may require additional stimulation, which is, I would say, a lot of my patients who are postpartum, even like 3, 5, 10 years postpartum that have decreased sexual satisfaction can be related to weakness.
Oh, totally. Or too tight. Their pelvic floor muscles are too tight.
Or changes in sensation because of like traction nerve injuries or something like that. But those typically can heal over time. But yeah, if you have less strength of your pelvic floor to do the actions required of an orgasm, which is a repetitive, contraction, very strong contraction. That if you have that weakness component, you might have less contact with whatever object you might be being penetrated with, but also with the clitoris may need additional stimulation to achieve orgasm because the muscles just aren't as strong and it takes a little bit longer to build the tension. that's required?
Yeah. I would say, kind of adding on to that, the biggest thing that I find is people will say there's a build up, and then it goes wah, wah, and nothing's really happening. And so if you think of the pelvic floor muscles, they're shaped like a bowl, right? And so they contract and relax like any other muscle in your body. Mm-hmm. So if you take your bicep, when you lift up something heavy, you don't do it with your arm fully extended, your elbow fully extended. You do it with your elbow slightly flexed. And so what that means is it's the length tension relationship. So we need the muscles to fully relax, to fully contract. Mm-hmm. And if your pelvic floor muscles are constantly tight, which is usually an issue due to stress, anxiety, depression, anything that's going to cause our bodies to go in that fight or flight mode, we're going to clench those areas. And so you can't lift up something heavy if your bicep is fully flexed. You just can't generate the force. And so what I see is that happening is that, people are just really, really tense and not breathing through their diaphragm, which helps relax those pelvic floor muscles. And then they're not getting that orgasm intensity. Do you see that?
Yeah, I see people. So when I describe orgasm function, I think this is from that master's study. It's like you'll go up into like a plateau. Mm-hmm. And then people will get stuck at plateau and they won't be able to achieve climax and then resolution. Yeah. So they get stuck at plateau, and it's from a number of reasons. One of them being the tightness. So when you become aroused, blood comes to the area like Mary was talking about. That helps with that elongation of the vaginal canal and engorgement of the clitoris. But if you have those really tight muscles, there's difficulty with blood entering the area. Sometimes the blood will kind of stay there and they'll be engorged and heavy feeling and uncomfortable. And then, we can't get that full range of motion to get that rhythmic contraction. What happens is they'll kind of get close. They'll do lots of little contractions and then sort of get literally stuck. Yeah. And then they have like discomfort afterwards. They feel like
some pain sometimes.
Just like heaviness too. And then it's not like an exciting experience. And so, they're like, I think I had an orgasm, but it wasn't like the ones they had maybe previously to having children.
Yeah. I mean, no, I definitely think it can be that. And the thing is, it can be a combination of a bunch of different things. We're just kind of listing out some of the reasons it can occur. So, what are the main types of orgasms?
So I am like, the way that I learned about them recently was there were like 3 different types, but I think now there's like
a ton.
There's like 10.
There's just an endless amount.
When I like read the 10, it was like, they just said body parts. So you'll have to tell me about those. It'll be like, you can have like a nipple orgasm. And I was like, oh, okay. I hadn't thought about it that way. But the ones that I know about is the volcano.
Okay.
The avalanche.
Okay.
And the wave.
Let's talk about those.
Okay. So the volcano is where the tension slowly builds over time. And then there's sort of like an eruption that is basically tension, more and more and more and more tension.
Yeah.
That releases.
Yeah.
And then with an avalanche, it is the tension basically builds, and then there's almost like a pushing down or a bearing down at the end. And then the waves is like building of tension and then relaxing, building of tension and relaxing, building of tension and relaxing. And so some people have all 3 different types. Some people just have one. Like I am for sure an avalanche, but sometimes I have a wave. And it was definitely different after I had my children because I have more laxity. And so that the laxity that I have actually, I think improved my orgasm function because I think I'm a baseline tension person.
Yeah.
But do you know what kind of orgasm you are?
I'd say probably you say the volcano? Yeah. But what I will say is after chemo, it was like this build up and then wah. And I would say it's probably due to the estrogen change because it was just totally it was just different.
Yeah.
It wasn't the same. And so I can relate in that sense and like, what's going on? Why is this happening? But
it's like you do all the things you did before and then you sort of get to this place and it's like, is this going to happen? Is this not? Now my clitoris is kind of feeling irritated. Yeah. Which like, I kind of want to go back to the clitoris to be like, one of the best things that we can do is be like, I prescribe for you 25 minutes of foreplay before you attempt vaginal penetration. Yeah. Like if someone wants to make me a prescription pad that says that, I would buy it. So I could literally just sign it and be like, give this to whoever you choose to participate in sex and sexuality with, because you require at least 20 minutes because the normal. Yeah.
What was the study that they had? It's like normal
time to achieve
orgasm was like
for women, which that's like a binary term. They mean vulva owners, but you know, for our purposes. So people with vulvas and clitorises typically take 25 minutes to achieve orgasm, and males or people with penises take 5 minutes.
Yeah, well, that's what I'm talking about with like the pornography. It's based on like, if you're not orgasming in 5 minutes, there's something wrong with you. It's like, no, like let's talk about this. I've also heard that it was upwards of 45 minutes.
Yeah, it could be. I mean, there's so much variation of normal. Yeah. And so the reason that I started doing 20 minutes is because then maybe, you know, if you feel like you want to participate in penetrative sex and you want to have an orgasm while your partner or object or whatever is penetrating you, then do 20 minutes so that those 5 minutes of penetration you can achieve an orgasm. You know, some people I'll say, because most people have the ability to orgasm more than once, people with vulvas. So I'm like, have an orgasm before you attempt penetration. See if you can enjoy it better. But like, it's more about like play and fun and identifying like what you enjoy.
Totally. Yeah. It's taking away, it's hard, right? Because women, for years, sex has been really about heterosexual sex. It's about the male partner. And, you know, like I said, everybody kind of grows up with different backgrounds of religion and what we've been told and things like that. But it's like, you know, when growing up, if a woman said they like sex, it was like, ooh, that's not okay. And so you internalize that. Mm-hmm. And then you're a 36-year-old woman and you're like, wait, that was just somebody's opinion. Mm-hmm. Let's look at the objective facts here. Objectively, these are the types, this is what can happen with clitoral stimulation. This is, you know, penetrative sex, right? And the other thing that we haven't really talked about too is the clitoris is not just what we see on the outside.
No.
Yeah. No, it has legs and it has bulbs and it's much bigger and it's underneath the sides of the vaginal opening as well. And that swells up when aroused. Yeah. And then, so that's also something that's important because if, you know, what I tell people is like, try direct stimulation, which means like right on the clitoris, or try broad. So like a hand, or try vibration, light touch, firmer touch, vibration. All of those sensations go up to different pathways of the brain. Mm-hmm. And so if you're not feeling the light touch or firm touch or broad touch, maybe you add in some vibration, right? And so there's vibrators for that stuff. And so it's just understanding the physiology of your body.
Yeah.
Right?
Yeah. So I think too, like I love how there's so much more emphasis on the clitoris because I have one and I think they're great. Yeah. But like what I like to tell people is the clitoral tissue is analogous to the male's like shaft of the penis. For sure. Like they're the same embryologic tissue. Mm-hmm. And so if we, I laugh when I think about it. If you thought about like asking a person with a penis, like, do you orgasm without anyone touching the shaft of your penis? Mm-hmm. You'd be like, some would say yes, they can, but I think a lot of people would be like, what? How would I do that? But I think we're basically saying the same thing about the clitoris.
I think that's a really good way to describe it.
It's like, well, do you orgasm by somebody not touching your penis? And that does happen. Yeah. Because sex is an orgasm. There's so many ways.
Different types of orgasms.
But I just find it humorous because they're literally the same embryologic tissue. So why would we not stimulate that tissue to
the lack
achieve
of
orgasm.
the lack of
Totally.
education. Like it's the lack of education, right? It's there's not this consistency of understanding our bodies. And so I think that's really important. But when I asked about orgasms last, what I actually wanted to refer to are just the types, right?
Oh,
so, you know, there's a big debate right now on whether the G spot is real.
Yes, there is.
Yeah. And so do you think it's real?
Oh gosh, you're going to put me to it. So I think personally that we have evidence that vulvas and erogenous zones and genitals have so much variation in how they are innervated that each person is so exquisitely different, which is great. So do I think that there are people that have increased nerve endings at the base of the bladder and therefore enjoy that? And so I'm like, I think that for those people, yes. Do I think that every single person has a G spot? I think probably not. But also I'm like, that's a good place for people to start looking. Like, let's just explore.
Well, I don't know if you saw, the recent study where basically they looked at cadavers and they saw there wasn't actually a spot. But what we're finding is that there's nerve endings, right? So you've got nerve endings going. So the G spot is really like if you have the vaginal wall, it's a couple inches up into the front of the vaginal wall. And so what you have, though, is you've got your bladder endings coming, and then you've got your clitoral nerve endings right there. So I think what you're doing is you're just stimulating a very highly innervated area.
Yes.
And then that can potentially lead to an orgasm. But what's interesting when I've talked to sex educators is that, you know, people want to know, like, what types of orgasms are there? And when I've talked to sex educators, they're like, anything can be an orgasm.
That's true. Yes.
And, you know, I think I still need to understand that a bit more. I think there's like maybe a euphoria, or sometimes people could have emotional orgasms. Yes. But really, if we're talking about it from like a physiological standpoint, there's really about three
that I know of.
Yeah, that are commonly talked about. So number one is going to be the clitoris. Number two is going to be the vagina, which is usually going to be that G spot area. And then three is the cervix. Have you heard of something different? Because, you know, the thing about this is that there's debate on if there's more or less, but those are going to be pretty common.
Those are common ones. I would say people have anal orgasms and they'll have nipple orgasms. Yeah. And people can also have orgasms touching other non-erogenous zones. And so, yeah, I'm thinking as you're talking about this, yes, I've heard a lot of like the sex educator realm, which I love this concept, just like we've sort of tried to unpack how sex needs to be about penetration. Yeah. Like I think they're also talking about chasing the elusive orgasm. Yeah. And what is an orgasm, and is the only goal of sex to have an orgasm. Exactly. And I think the point that they're trying to make is like questioning to be like, why do we have to chase this elusive orgasm? Why can't we enjoy just the experience and not just be like, I have to orgasm or I'm a failure, which to me is like a very American
It's
thing.
very, yeah. No, I think that's right. I think it can be everything, like at least the culture that we grew up in. We were talking about like the baseball analogy. First base is touching the boobies. Yeah. Second base, I don't know. Touching the genitals. Third base, oral. Home run is penetration, which is all total BS. Yeah. Any touching of the genitals is a form of sex. And so I think, you know, a lot of sex education and stuff for the people that are staying up to date, we're kind of talking about just sex in general. So we talk about sex, which could be oral sex, touching, penetration, all these different things. And that's why we're clarifying penetration, because some people don't necessarily have penetrative sex. Yeah. And that's, you know, if that's something they don't enjoy, then they don't enjoy it. And that's not, you know, my thing to talk about. But the point is that all these different things are considered sex, and talking about them in that way. And just because you don't orgasm doesn't mean you're a failure. It just means that you enjoyed that time with your partner and you didn't. And that's okay. So then maybe the next time you do or not. But if you keep putting that pressure on yourself, oh gosh. I mean, that's like,
it's too much.
Yeah, it would be like if you, for instance, like if you had, if your partner couldn't get ejaculate, right?
Yeah.
And like every time they didn't ejaculate, like they felt like a failure. It's like, well, that's not fair because there's other things that go on as well that might limit your ability to do that. And so we know it tends to be harder for people with vulvas to achieve orgasm than their male counterparts, right? We just talked about 5 minutes usually.
Yeah. Well, and like I'm thinking in my mind, I don't have a picture of it, but there's like if you look at the male sexual response cycle, it's basically like a logarithmic curve and then it drops down.
Yeah.
And if you look at the female sexual response cycle, it's like a circle with a bunch of arrows and then there are all these arrows pointing in.
Yeah.
And so it's like so many things impact arousal and the sexual cycle in people with vulvas.
Totally.
And so physiologically, there's just more that can impact the sexual function that can make it, which can be a good thing and a bad thing. Like,
well, what Emily Nagoski talks about in her book are just like the brakes and accelerators.
Yes.
Right. So accelerators are things that increase your desire or arousal. And then the brakes are things that slow it down. And generally speaking, with life, we have a lot of brakes, especially if you have kids, right? If you have 3 kids, there's a lot of stress going on. There's kid stress, there's work stress, there's time stress. There's a lot of things that your brain's going to be focused on. And if you are focused on that all day, and then at the end of the evening, to shut that off is going to be kind of hard. So what are some things you can do to kind of calm your nervous system and increase the accelerators? Like maybe you need to tell your partner or something, hey, I'm feeling XYZ during the day. Maybe I'm feeling like disconnected from you during the day. Yeah. Okay, well, what can that person do to help improve that connection? So at the end of the day, there might be,
time or
feelings of intimacy. And so there's a lot of things. Some people are more turned on physically. Some are more turned on emotionally. Some are turned on both ways. And the key is everybody's different. Everybody's nerve endings are different.
Yeah.
And so it's hard to say specifically, this is what you need to do. Yeah. And so what we can do is kind of give these guidelines and like, hey, this is where sexuality is at right now. It's, now you can take some time and kind of feel these things out and see what works best for you. But, the other thing that's important too to discuss is like there's desire to have sex, and then there's arousal, which is like the genital arousal to allow for penetration. So those are two different things as well. And what I tell people, and this is something we've talked about, is that when you're breastfeeding and you're secreting oxytocin, which is that love bonding hormone that we secrete during sex. And so what can happen is that you're receiving that, so you may not desire sex during that time, which also you might be exhausted, the babies, people hanging on you, stuff like that. But like from a hormone perspective, you may not be desiring it because you're already getting that oxytocin from breastfeeding. Yeah,
definitely.
But you can get aroused. So that's why I tell people, like, talk to your partners about this.
Yeah, and I think that, the more that you feel safe talking to other people, there's so much common humanity. So many people have these experiences. So I have 2 kids at home and we all sleep in the same bed. And so the mechanics of intimacy in me and my partner is like, there's not space, there's not time, there's not energy. And then, so much of this we're talking to patients about. I just like to normalize it. Like we're here with you, we're people. And so it's like when you are postpartum 10 years, 3 years, you are distracted too. And so that can also impact your ability to orgasm.
Totally. Yeah. There's so many factors. And so, there's a lot to unpack here. And really the moral of the story from a lot of this is just, understanding your own wants, desires, and you may not even know. Most people don't know. I do find that, there, at least in the US, there's a culture where people that have given birth, so, mothers, there's almost this, culture of just give. Yes. And what happens is that people tend to lose themselves in that process. and kind of develop anxiety and just feeling overwhelmed because they're not filling up that cup, which can be affected by a variety of different reasons, right? And so life is complicated, but also if that sounds like you, maybe this is the first step of just being and just seeing what your body likes.
Yeah, I mean, I think that like we are pelvic floor therapists, so we are biased. And so I'm like, I think if you have decreased sexual satisfaction, it could be beneficial for you to talk to your OBGYN and ask for a referral to pelvic floor physical therapy just to get an assessment. What I think a lot of times we can do, one of our strengths is we can definitely assess the musculature, but we can talk through this and sort of like have a place for people to talk to, but like through the airways, like I think the best way for people to start doing that work on their own is like look up sensate focus, like talk to your partner and think about adding like play in your life. I mean, obviously if you
play is huge, and it's so, you and I were just talking about this. We live in this urgency culture where people are just go, go, go and on autopilot. And it's like I said, life is hard. There's a lot of things that can happen, and there's a lot of different things, but there are also small joys in life that
so many
you can have. And, you know, even if it's just taking 5 minutes a day to just think about what you want, or if you have a bunch of kids hanging on you, go to the bathroom and just in the shower.
My bathroom doesn't have a lock.
But, well, you got to figure that out.
It feels like a beacon. I go in there and everyone's in there. I'm like, no one even.
What is happening at your house? Everyone's just
a lot of things are happening.
a lot. I love it.
Yeah, I think it's good though, Gina, that you wrote to us because I think. Well, I know that so many people have this exact question.
Totally. So many.
Literally, it fills our offices, and it's. Again, I like to say that it's a common experience because I don't want you to feel like guilt or shame about being the only person. And like there are things that we can do to change things. And it can be really vulnerable too to talk about orgasm function.
Totally.
Especially if you're like, I don't know how this is going to be received. Like, what is this provider going to be like? Well, here, I don't know. I don't orgasm either, or whatever, you know.
It's like, oh, that's not really helping anybody. Yeah. But I mean, you can go, you don't necessarily, like in certain states, you can go directly to your pelvic floor PT. But I would say, you know, pelvic floor PTs are the people you want to ask these questions to, and, you know, they'll normalize it. And if you feel like anybody is not taking your questions seriously or anything like that, obviously just find another provider, because there's a lot, you know, you need to find a good fit.
I just want to be like, that is not a you thing. That is a them thing.
That's a them thing. There's a lot of ego. Yeah.
But I can also tell you, like, I think our work requires a lot of like self-work, like
totally. The amount of therapy I've done. Oh my God.
Which has been great for my career and my life. But like, you know, I knew and I know that I have had my own discomfort talking about sex and sexuality. And so I was like, oh, this is going to impact my ability to serve my patients. So I need to work on this. And, you know, so if somebody is like having a weird reaction to you sharing this, it's like that is not because you're weird. It is because they feel uncomfortable. Yeah. And that sucks. And I have compassion for all of you. And yeah, unfortunately, you might want to think about finding someone that feels a little bit more comfortable talking about sex and sexuality.
Yeah. Yeah. So hopefully that helped you, Gina. And just to kind of summarize the things that we discussed, hormonal changes can potentially affect this, especially in the postpartum breastfeeding phase, perimenopause, postmenopause, and also potentially during or post-cancer treatment. The other thing is knowing your body. Yep. So knowing what areas you like to stimulate and being able to communicate that with your partner and maybe exploring that together. And yeah, just understanding that everybody has different nerve endings, and then understanding that everybody's orgasms may be different. And then finally, if your pelvic floor muscles are too tight or too weak, that can also affect the orgasm intensity. And then finally, really discussing emotional parts of your relationship. If you're in a relationship, that will potentially affect your desire to have sex. And then I did say finally for that one, but then finally, is to really, just take some time for yourself and really understand yourself. Mm-hmm. And like I said, that might be 5 minutes in the bathroom, which this wouldn't work out for Adrienne because she has no lock on her doors.
I could get a lock on my door.
Hey, do what you got to do. No judgment here. And so we're really appreciative of you to send us that question. And Adrienne, how can people find you?
Oh gosh, I am on the social medias, but due to my mental health, I'm not there often. But that's probably a good place to find me. Okay. My Instagram handle is @AGobePT.
AGOBEPT. Perfect.
And there you will find lots of me talking about vulvas and sexuality. Perfect. And anxiety.
Anxiety comes in. Yeah, we could talk about our anxiety all day.
For days.
And finally, you can follow me at drmarypt on Instagram. And in the show notes, we'll also have a link for you to sign up for 3 tips on how to stop leaking while you exercise. And so that way you'll get on our newsletter when you get that too, and you'll find out when we have more shows coming up. And we're going to be talking about a lot of different things that you're too afraid to ask your healthcare providers about. So thank you so much and have a great day.
Thank you.